Hi, my name is Brian Apavu. I am a neurologist with an interest in philosophy, the mind, and living the examined life. Today, I want to dive into how we think about consciousness in terms of real world problem solving with an emphasis in the clinic. Core metaphysical questions of consciousness remain unanswered. The scientific method has not, at this point, been able to address some major questions we have regarding the metaphysical counterarguments to materialistic concepts of what consciousness is. Meaning, how do we get beyond Rene Descartes' concept of I think, therefore I am? Nevertheless, at its core, our scientific method has allowed us to do something that we all value, and that is solve the problems that we have. In hospitals and the clinic, we, in one form or another, aim toward helping patients that are in front of us with challenges that involve their conscious experience. In the world of epilepsy, the International League Against Epilepsy has epilepsy classifications that historically have had consciousness as a critical role in determining seizure types. The first classification made in the 1960s, 1970s didn't actually provide a definition for consciousness. The 1964 1970 classification of partial seizures was partial seizures with complex symptomatology, with or without impairment of consciousness. Now, that definition was made without actually saying what consciousness was. In 1981, there was a little bit more of a description where from the ILAE, where they described complex partial seizures as being either with or without impairment of consciousness. And there they define consciousness as integrating activity by which man grasps the totality of his phenomenal field and incorporates it into his existence. This operational definition of consciousness was all about awareness and responsiveness that allows for recall. In our latest classification from the International League Against Epilepsy of epilepsy types and seizure types in 2017, they described focal onset seizures with impaired awareness, where here they classified consciousness as multiple types, where the surrogates matter awareness, responsiveness, memory, and sense of self as distinct from others. Here, the operational definition of consciousness had something to do more so with awareness and less to do with responsiveness being tested. The ICU has been a central part of my professional experience relating to consciousness. Patients present with brain injuries and appear in a comatose state. In neurocritical care, our first principles are regarding neuroprotection. All guidelines that exist in neurocritical care advise against early prognostication. The first goal of care is to stabilize the patient and protect the cells of the nervous system. The foundation of our neuromonitoring and critical care interventions in these early days, typically within the first 72 hours, are focused on the concept of neuroprotection. There comes a time, however, where we are necessitated to ask questions about neurologic prognosis. Our palliative care teams are instrumental at eliciting from caregivers regarding what values and attributes that families desire in their hopes toward good neurologic recovery. In patients with coma, this often comes down to questions regarding consciousness. This can be as instrumental as to whether their loved ones will quote unquote wake up, but it also can be more nuanced into questions surrounding their capacities and the level of agency and sovereignty that their loved ones would be at capacity to recover from. As neurologists, our fundamental process of evaluating consciousness has always relied on the neurologic exam. The neurologic exam has been our historical method of eliciting outward responses from patients in an effort to derive an understanding about the more intrinsic nature of neurologic disease. Like detective work, we perform an exam, we observe a set of normal and abnormal phenomena, and then we create conjecture, combining our knowledge of human physiology and our observations of the patient regarding what is wrong with them. From this, we may perform a variety of other advanced studies to garner a more complex understanding. And now, with functional magnetic resonance imaging as well as electroencephalography, we can grasp a little bit more about what happens within the internal state. Our exploration of consciousness through the neurologic exam remains insufficient. It doesn't overcome the issues put forth by our predecessors focused on metaphysics. We can extract much from the neurologic exam, but we are limited toward our understanding of whether the patients in front of us are at capacity toward demonstrating what Rene Descartes demonstrated as a self evident truth: I think, therefore I am. It is from this that we have entered the space of exploring disorders of consciousness. One of the current issues that we have in neurocritical care and neurology is that at present, we are not very good or accurate at early prognosis of brain injuries. Our data just doesn't support high level evidence that very specific biomarkers that we identify early after a brain injury necessarily relate to long term outcomes. At present, we have issues regarding our ability to provide an accurate neurologic prognosis. In neurocritical care, we worry about the self fulfilling prophecy of early withdrawal of life sustaining therapy. The concept comes up a lot in neurologic prognostication research. It describes how clinicians' expectations can inadvertently shape patient outcomes. In this scenario, there is an initial prognostic judgment. After severe brain injuries like cardiac arrest, traumatic brain injury, or stroke, clinicians often prognosticate early based on exam findings or other early biomarkers. These judgments are made under a degree of uncertainty, since the early neurologic exam can be confounded by a variety of variables, and we simply do not have at this current time or in prior times great biomarkers that predict long term outcome. If the initial judgments are pessimistic, clinicians may recommend or initiate early withdrawal of life sustaining therapies. Families, trusting the medical team's expertise, frequently agree with this course. This leads to a causal loop. Once the withdrawal of life sustaining therapy occurs, the patient dies, not necessarily because of irreversible brain injury, but because support was withdrawn. Thus, the prediction of poor outcome is confirmed, but not because it was inevitably true, but rather it became true due to the treatment decision. This creates self reinforcement. Over time, these cases reinforce the belief that certain early exam findings or certain biomarkers reliably predict poor outcomes. Yet, this belief is partly based on circular reasoning. The patients never had the chance to demonstrate recovery because the therapy was withdrawn. This has enormous consequences for medical research and medical evidence that's generated. This cycle introduces prognostic bias in outcome studies. Patients who might have recovered are excluded from the good outcome pool. It inflates the apparent reliability of early prognostic biomarkers and reduces the evidence base for delayed recovery. This bias is especially important in coma research, where timelines for recovery can be prolonged. In short, the self fulfilling prophecy of early withdrawal of life sustaining therapy happens when early pessimistic prognostication leads to therapy withdrawal, ensuring death and making the prediction true, even though the patient might have otherwise survived or recovered. This phenomena is exceptionally important in medical research now. We want to create studies moving forward that exclude patients who were withdrawn due to the decision making of withdrawal of life sustaining therapy in terms of our overall prognostic models. One of the issues that I've discussed in the past is that consciousness studies suffer from the fallacy of reification, where we are using words very commonly to mean different things, and therefore we cannot achieve consensus or better explanatory theories for what the phenomena we're trying to describe is. We're all thinking about them very differently. The psychologist George Miller famously described in the 1960s that consciousness is a word worn smooth by a million tongues. Maybe we should ban the word for a decade or two until we develop more precise terms for the several uses for which consciousness now obscures. The challenge that we have in light of this issue of reification regarding the word consciousness is that we need to narrow the subject matter of consciousness to definite points where it can be experimentally tested in a way that we can use it and harness it to solve real world problems. When it comes to consciousness and our ability to go from a philosophical concept to a more rigid science, we can look at the primary components. Plum and Posner classified consciousness as a state of full awareness of the self and one's relationship to the environment. They classify the contents of consciousness to primarily be that of arousal and content. Arousal has a lot to do with vigilance or our state of wakefulness. Content can be broken down into other components, such as attention or the ability to focus on mental resources onto specific pieces of information, as well as conscious access, the ability to attend information that enters awareness and becomes reportable to others. When we think about acute altered levels of consciousness in an intensive care unit setting, we typically classify it under a variety of different categories. Clouding represents incomplete orientation to time or place, inattentiveness, and difficulty repeating numbers. Delirium represents florid abnormal mental state characterized by misperception of sensory stimuli and often vivid hallucinations. With delirium, you have disorientation first to time, then next to place, and then to persons within the environment. The obtunded state is one with mild, reduced state of arousal or vigilance with less interest in the environment. This may be drowsiness during sleeping bouts, but responsiveness that can be maintained for certain periods of time. Stupor represents a state where a patient can only be aroused with vigorous and continuous stimulation. And once that stimulation is removed, the patient appears unresponsive. And then coma represents a state of unresponsiveness in which the patient lies with eyes closed and cannot be cannot be aroused to stimuli even with vigorous stimulation. We know that the ascending reticular activating system is very important to our ability to maintain alertness and to the degree of vigilance that we have. There are multiple nuclei within the brain stem as well that is the thalami that interplay with each other, and this leads to a corticothalamic activity that is necessary for arousal and wakefulness. We do know that from a variety of clinical studies as well as animal model studies that if we have certain types of injuries in certain areas, we will have coma. And these are what we refer to as structural coma. We know that bilateral diffuse cerebral cortex damage can lead to coma. We also know that when both of the thalami are affected, we are not able to have arousal and attention. And then there are very specific nuclei and segments within the brainstem that can lead to impairment of consciousness, and they are very unique. And you can have brainstem injuries that lead to consciousness, and as well as those that do not. When we think about disorders of consciousness, we can break them down into those that are chronic disorders of consciousness as well as those that are acute disorders of consciousness. When it comes to chronic disorders of consciousness, we think about this in patients who are more than 30 days out from a brain injury. If they have no evidence of eye opening and are completely unresponsive, we think that they are in a coma. If they have some signs of eye opening but no other responses, we worry that they have unresponsive wakefulness syndrome. In the outward assessment of these patients, if they have some purposeful movements or command following, we might think that they're in a minimally conscious state. But if they have greater degrees of command following or functional communication, but are not quite themselves, they might be in a confusional state or have cognitive dysfunction. In patients um, that have brainstem strokes, like a pontine stroke, but they otherwise internally have the capacity to do everything in regards to communication and command following, and for many patients, be able to open or be able to move their eyes up and down, we think that historically have characterized them as having locked-in syndrome. Now, these patterns of describing consciousness in relation to outward movement and outward command following, outward signs of it, have led us to this sort of classification. But using advanced techniques where, like functional magnetic resonance imaging and electroencephalography, where we can actually find signs of some form of conscious awareness or conscious processing, we move into a different domain where we think about other ways of classifying this. If patients have evidence on functional magnetic resonance imaging or EEG suggesting that they can actually follow commands, we call that cognitive motor dissociation. If there are some patients who may not just overtly follow commands, but they have evidence on EEG or functional magnetic resonance imaging that suggests that they um, their brain recognizes or reacts to novel stimuli in the environment, new sounds, novel words, and so forth. We call that covert cortical processing. This is representative of processing suggestive of consciousness, although you may not have the full um, motor command following. With resting state functional MRI, we now have the ability to look at intrinsic functional connectivity in the brain and the network, the integrity of specific brain networks. And we identify that that the intrinsic functional connectivity seems to differentiate patients who are unresponsive, who have unresponsive wakefulness than as compared to patients who appear in a minimally conscious state. This is one of the studies that sort of distinguished the two based on functional connectivity. And this leads to some promise that whether we can use functional MRI to be able to actually identify which patients are at capacity for recovery because their networks are at baseline very healthy. Now, functional magnetic resting state fMRI is not able to tell you directly if a patient's conscious following commands or not, because it's not actually providing a stimuli to the patient or asking them to follow a command. But this resting state activity can be very useful. Resting state EEG can also be useful as well. When we look at brainwave activity across the frequency domain and look at the EEG power spectra, we can see a variety of different patterns that are associated with um, consciousness. So in those patients who have predominantly 1 hertz frequency or less, we think that their corticothalamic activity is completely deafferent, and they have quiescent or non activating central thalamic activity. And these patients are often in a coma or in an unresponsive wakefulness state. When we see patients who have a high degree of delta activity or low frequency activity, but they also have a burst of activity in the 5 to 9 hertz range, we think that their corticothalamic activity is severely deafferent, but not completely deafferent, and they may be in a minimally conscious state. This also can be seen in patients who have an EEG power spectra with some dominance in the 5 to 9 hertz range, as well as some relative faster frequencies. And then these patients might be in a confusional state. And then if you have robust activity in these domains, this is typically seen in healthy individuals. We can also use resting EEG to look at things like functional connectivity and information sharing or information complexity, and this seems to be associated with a recovery from coma and an improvement in consciousness. In 2002, Owens and his group published a landmark study in Science that showed that a patient that appeared otherwise in a vegetative state or in unresponsive wakefulness was able to actually demonstrate signs of of motor imagery, where where the patients were able to imagine moving around a house or playing tennis. And this was recognized as the initial study that showed us that patients that appeared otherwise unresponsive were actually having signs of consciousness based on advanced testing using specific tests. This was published in Science in 2006. More recently, there is studies that show that task-based fMRI can be useful even in acute settings. So this is a study by Brian Edlow and his group at Massachusetts General Hospital that demonstrated that there are patients that have evidence of recognizing language, of recognizing music, and having some motor image and responding to motor imagery tasks that seem to be associated with some signs of being somewhat conscious. So there's promise that this can be useful even in the acute setting. You have to be careful. This task-based fMRI is based on blood oscillations, and brain injury can be associated with hyperemic blood responses and unusual responses. But there's some promise that's here. EEG is task-based EEG is showing incredible promise as well. This is work from Jan Klassen and his group at Columbia University, published in the New England Journal of Medicine in 2019, that showed that when you put headphones on patients and ask them, unresponsive patients in the ICU, and ask them to squeeze their hand or not squeeze their hand, there is an EEG response that could be seen in response to that command that is similar to that which you can see when you do it on healthy individuals. This is for a select cohort of these subjects. So this is evaluated in terms of EEG power spectral density. The group used a support vector machine algorithm algorithm. This is a machine learning algorithm to classify patients that had command following and who didn't command following. And those who seemed to have command following were classified as having cognitive motor dissociation. So in this study, they demonstrated that 15% of unresponsive patients in their adult intensive care unit who were enrolled in the study demonstrated the changes in the EEG power spectral density suggestive of command following, affirming the diagnosis of motor command dissociation. And those patients with motor command dissociation had a higher likelihood of favorable outcomes 1 year after the injury. Now, I talked about actually follow task-based studies that actually ask a patient to follow a command, but we have patients, particularly children or those with some impairments in attention or maturity, who may not necessarily be at capacity to follow a direct command in an ICU environment, particularly by individuals or voices that aren't familiar with them. But we might be able to harness passive tasks where we don't have to ask them necessarily to do anything, but we can give them novel stimuli and see how they respond. And this is where work with the recursive processing theory or global neuronal workspace theory really come into play, where we look at evidence of response to passive tasks and evidence of unconscious or conscious activation to novel stimuli. So this is just an example. If a child is shown a number of a series of letters, some of which representing word and some that don't, as well as things that letters that represent a number or an actual number itself, you can see different types of responses and a brain index of response preparation. And you can see either unconscious activation or response execution. So if the stimuli is shown in a very short period of time, the patient may not be necessarily recognize the novel stimuli, but their brain can activate to it. And you can see a low amplitude response fairly quickly after the stimuli, which is representative of unconscious activation. Now, if that novel stimuli is provided with a sufficient duration or a more obvious recognition of being novel, and a combination of these two things, you can get a very robust response occurring several milliseconds after the stimuli is provided. And this is suggestive of response execution or actual conscious activation where the patient recognizes the novel stimuli. So with this, we can use this type of science and these type of experiments to represent conscious and unconscious recognition of stimuli, whether it be error detection, key presses, numbers, meaning of phrases, facial recognition, reading, sounds. This all can be experimentally tested at this time and be useful in clinical environments. This all is consistent with global neuronal workspace theory of consciousness, where if you provide a stimuli, without a sufficient um, without a sufficient cue, it might be a short duration cue or whatnot. There can be subliminal processing of that where there's bottom-up propagation, and that propagation has a failure of ignition to necessarily become part of conscious awareness. But if this stimuli is provided with a sufficient amount of response, whether it be a longer duration where that novel stimuli is provided or something that just makes it more obvious, then you get ignition of the global neuronal workspace. You get ignition where you go beyond either the occipital lobe for visual stimuli or the temporal lobe for auditory stimuli, and then you start to involve other networks, including the frontoparietal networks and the parietal and prefrontal cortex. And this is representative of conscious access of the material. There are unique ways to investigate covert cortical processing in unresponsive patients. There is a paradigm that is studied called the local global oddball paradigm, where you provide a series of tones and then you change the pattern of those tones, and you change it with local deviance, where you have a series of 5 tones and you're just changing the pitch of the 5th tone, or global deviance, where you have a certain pattern of those 5 tones and then for a certain series. And then you suddenly change it. And from this, you can get different types of responses on EEG. You can get the mismatch negativity response, which typically occurs around 130 milliseconds after the stimulus. Is a low amplitude negative response that is suggestive of unconscious processing to local novelty. Patients may not fully recognize these sort of responses, but it's indicative that there is some degree of bottom-up propagation. And then but then if the stimuli is robust enough and you're dealing with global deviance, then you can have conscious responsive to the global novelty where there is ignition of that global neuronal workspace and you become consciously aware of that novelty. And these have been tested in ICU environments and in comatose patients and show a great deal of promise as a way to investigating for covert cortical processing and signs of consciousness without actually asking a patient directly to do something. These techniques of looking at unconscious and conscious processing are fascinating, and they also are being applied outside of the clinical environment. In the criminal science realm, there is something called fingerprinting or concealed information testing, where witnesses of a crime or even potential suspects of a crime are asked to look at or listen to certain stimuli that might have been at the scene of the crime. And here, b- subjects are evaluated for whether they have event related potentials that suggest that they either have a conscious awareness, even though they may not outwardly say it, or even subliminal processing. So this science is emerging and it's being looked at not just in the clinical domain, but by others as well. And this leads to a whole host of questions that are ethical in nature, in terms of the value and when and where we should be doing this sort of testing. There are techniques that are emerging that go beyond EEG or fMRI. There is a technique called transmagnetic stimulation where you can provide a stimulation to a certain portion of the brain and using EEG look at a response. There's evidence that's emerging that in patients that appear in an unresponsive wakefulness state or that don't have signs of consciousness, that when you provide a stimuli, you get a certain type of an EEG response that doesn't have a lot of complexity to it. But in patients who are emerging and recovering from coma or have some signs of that, that when you provide the stimulation with the with TMS, the EEG response can have increased complexity to it. So this is something what we refer to as the perturbational complexity index. And more work is being done on it. It shows a lot of promise as a way to not to perhaps to provide therapy, but also to evaluate the efficacy of therapies being provided. So the ultimate goal in this ICU level care, this clinical care of these tests that are looking at covert consciousness is to be able to identify whether we can use these techniques in unresponsive patients and evaluate them at a high level and determine the likelihood that patients are going to recover from coma, as well as what is their actual conscious state or their inner state while they appear unresponsive in front of their loved ones and other clinicians. There are a variety of therapies that are potentially available and being offered, some of which and being in the clinic, being offered in the clinical setting now, including what we call coma cocktail medications. Now, all of these medications are intended to largely act on the state of arousal of a patient that appears in a coma, and look at and improving their degree of vigilance. But these all act on the mesocircuit frontoparietal um, um, networks. So medications like amantadine, methylphenidate, apomorphine, zolpidem have been used to try to target the striatum or global pallidus interna, and so forth, and deal with neural circuitry arising from those different areas. And then we also have neuromodulatory therapies such as transdirect current stimulation, transmagnetic stimulation, central thalamic deep brain stimulation, low intensity focused ultrasound pulsations, as well as vagal nerve stimulation that are currently being tested to try to act on the thalami as well as the cortex. The there are studies that are ongoing that have looked at these different resting EEG or fMRI measures as a way of assessing for the efficacy of various therapies. So this is work done that show in patients with acute brain injury that show that for those patients who receive amantadine, there are changes in their EEG power spectra that suggest that the medication is working and helping patients in terms of their brain injury recovery. As I mentioned, there is a phase one randomized feasibility study that recently was performed by Nico Schiff and his colleagues at Cornell University, which is published in Nature, that show the feasibility of performing deep brain stimulation to the central lateral thalami in patients with chronic disorders of consciousness. And in their work, they showed that it's fairly safe and feasible to perform this study. And you can see unique event related potentials and change and evolve as it relates to the initiation of. Um, Central thalamic deep brain stimulation, as well as changes in clinical findings. And this shows promise that we can move toward more advanced clinical trials to see if this can improve patient arousal for patients with disorders of consciousness. Brain-computer interfaces are a hot topic right now and are emerging with companies like Neuralink and others and BCI groups all across the world. And there's a lot of promise that for those patients who have severe neuromuscular impairments but relatively healthy cortices, that you can harness parts of the cortex to be able to recover some of the function that otherwise has been diminished because of disease. So this is an example in patients with ALS, that being able to put a brain-computer interface over the motor cortex or over the language cortex, patients are able to have a speech neuroprosthesis that allows them to speak again, whereas their neuromuscular condition otherwise would not have allowed them to. There is work that's ongoing that as to whether you can do this in patients with stroke who actually have damaged tissue, to actually see if you can recover that function, even in the setting of damaged cortical tissue. And so this work is exciting and emerging. Now, with all of this work, especially those with passive tasks and looking at subliminal signs of consciousness or elements of consciousness, we have to talk about the neuroethics of what this is going to represent. What does it mean when we can tell individuals are subliminally processing information a certain way, but not outwardly giving it to us with their own agency and sovereignty? At what point do we recognize that their actions are who they are versus their thinking? Depending on how old you are, you may recognize the movie Minority Report, which featured Tom Cruise, where the story was all about determining a crime before it occurs, and predicting it and being able to identify whether people were going to commit a crime before they actually did. If we are able to get to a point where we can actually process the thoughts in individuals, at what point are we going to be able to provide them with sufficient sovereignty, where we respect them for their actions rather than their thoughts? This is something we need to start thinking about now in an era where we are getting the actual capacity to recognize subliminal processing. It's something we got to think about now before the technology arrives in the future. There are other practical aspects of neuroethics research related to covert consciousness now. A lot of this work right now is in the research domain, and the use of research data in context of clinical care can be appropriate based on whether the data is actionable, and what emerges from the data. This is something that we need to understand in the situation where these tests have not been fully validated. Factors include the potential health significance of the results, the validity of the test, risks and benefits of disclosing the information, as well as the utility of the information. There are individuals who feel like patients have a right to know this information, even if it's not valid. And there are others who are concerned that if we're still trying to understand how this kind of tests work, and we don't really understand either their prognostic implications or what they're really telling us, that you may be conferring a certain amount of risk by using it clinically for patients. And we have questions that we need to ask regarding this information. How do we actually truly know if somebody is conscious? It seems like if we can determine that they actually are able to follow motor commands, that seems like it's a pretty good test. But with these passive tasks, or these tasks that represent covert cortical processing, it gets a little bit more challenging. The global neuronal workspace theory and recurrent processing theory, integrated information theory, these allow for empirical testing of attention and conscious access, but they remain limited in describing phenomenal awareness, our intuitive feeling that our experiences possess exclusive qualities that are personal and subjective. Some argue that that the only consciousness we truly know is our own. Again, Rene Descartes' famous statement, "I think, therefore I am." Activation of the brain to familiar voices or novel stimuli suggests cortical processing and may be ethically significant to determining a state of sentience. But what does it actually mean to have some of these signals that we see in consciousness be there, but others aren't there? Is it possible that you might have some sense of some signs of covert cortical processing in a patient that doesn't have the capacity for vigilance? I don't know. We don't know that yet, and it's stuff we're still trying to figure out. And once we do, let's say a patient's brain activates the novel stimuli, but they don't have the arousal mechanism. What does that mean? That's something we still have to figure out. We also have a difficulty in knowing whether a negative test is truly negative. In many of the studies that are being done with covert consciousness, it seems like a positive response indicating covert consciousness is associated with a favorable outcome. But there are many patients who do not test that have a negative result that end up doing great. And there is challenges in knowing what it means to have a negative test. Does it mean that they weren't able to follow command or just activate in that particular time? Does that necessarily mean that they will never wake up again? It doesn't seem like the data has been really robust in terms of showing that a true negative test is predictive with high accuracy of a poor outcome. And we need to be mindful of that when we introduce this information to families. I hope you enjoyed this video. If you did, I would appreciate if you could subscribe to the channel for new content and like this video. I will talk to you again soon.